Hey guys, Kim here, and you are tuned back into Kim E, the Diabetes MP. Well, today, as we're now in January of 2023, what I would like to do for the month is go over and give my commentary over the newly released ADA standards of care. Okay, they're always released in December, and it's always exciting to get them. There's updates. You can kind of see what's still the same. Um, you can see what's changing and how you would need to adapt your practice. And so I started doing this. Well, I tried to do this last year, but it was just a lot to kind of keep up with. But I think I have a good plan to get through all of them. There are 17 standards, 17 sections. That's more than what was last year. I think it was only 16 last year. Not quite sure, but there's been some recent changes, and I posted on my social media platforms and just some things that I had noted already as I was starting to read through the different sections. And I posed the question, would you all want me to do a review? Now, and a lot of people said yes on across all of my platforms. So I thought this would be really good to do. And you all can we can just kind of have a little chat here. You know what I'm saying? Now, what I will say is this. My plan is not to cover and go section by section by section, paragraph by paragraph. I'm not going to do that, mainly because I feel like everyone needs to be familiar with the standards. The majority of people who practice, if you see patients, you're going to come across somebody who has diabetes, and you do need to know where to go get them, where to pull up the document. And if you don't read the whole document, because it is pretty lengthy, at least pull the standards that are relevant to your practice and your demographic. I'm going to encourage you to do that. So basically what I'm going to do is just give you my thoughts. I've read through some, and I've read through the document, and I have highlighted things that were interesting to me. So that's what I'm going to talk about, and just like, a commentary, just like what my thoughts are about some things. I'm excited about it. I like the progression of it. I've been reading the standards for the past few years regularly and routinely. And so it's really good to see how far we have gone. Still have far to go, but it's good to see the change and the progression. So today, what we're going to talk about, we're going to do, I don't know if you can see this, but we're going to do the first section, standard 1, which is improving care and promoting health in populations. Now, before we get into this, let me tell you what my plan is. Hopefully, I'll be able to stick with it. But for January, we're going to go through every standard, okay? I plan on doing a live 4 days a week, okay? So this week alone, we're going to do the first 4. The next week, we're going to do the next 4, and so on and so on. And so that means that my plan is to post Monday, Tuesday, Thursday, Friday. Okay. And because of that, we won't be doing our lunch and learns. Consider this like the lunch and learn. Okay. But not really, but it's special series, and that's what we're going to do for January. So I just want to let y'all know, haven't quite decided when I want this to go up. It will probably be the same time. Today is not going to go up at 11:30, but the rest of the days are going to go up midday. Probably I'm going to shoot for 11:30. So just so you know, you can come back and meet me here Monday, Tuesday, Thursday, Friday, and this will be streamed. This is streamed to YouTube, LinkedIn, and Facebook. Okay. And so let's get right into it. I do have some notes, but in an effort to kind of get it done and get this up for you all, I didn't make notes on all of them, but I highlighted as I went. So I probably will dip down and look at those and stuff. So if I have to pause, please just bear with me. Okay. So, like I said, the first standard is improving care and promoting health in populations. And so, out the gate, what's happening here is they're defining for you what population health is, how it relates with diabetes, and the first section is called diabetes and population. So, what I will do is throughout the document, you'll see this gray little box here, and it's different sections in the document, but what will they give their overall recommendations. So what I'll do is read those, and then we'll just get into it like that. So the first section is diabetes and population health. And basically, it's saying here to ensure treatment decisions are timely, rely on evidence based guidelines, include social community support, and are made collaborative with the patients based on their individual preferences, prognosis, comorbidities, and informed financial considerations. Next, align approaches to diabetes management with the chronic care model. We'll talk about what that is here in a little bit. This model emphasizes patient-centered team care, integrated long-term treatment approaches to diabetes and comorbidities, and ongoing collaborative communication and goal setting between all team members. Thirdly, care systems should facilitate in-person and virtual team-based care, including those knowledgeable and experienced in diabetes management. And then also lastly, assess diabetes healthcare maintenance using reliable and relevant data metrics to improve processes of care and health outcomes with attention to care costs. So that's the overall ideas, topics. And so they do the first line out the gate, they define population health, which is defined as the health outcomes of a group of individuals, including the distribution of health outcomes within the group. And so clearly, as we know, statistically, diabetes is, it's rampant. We know the numbers are high. It's definitely a population health issue. This also talks about, let me see here. So our outcomes, our optimal outcomes for diabetes care, they are telling us that they must be individualized. And so the thing why I wanted to highlight that is because oftentimes, I've said this a little bit, but oftentimes when I'm having conversations with other clinicians, healthcare professionals, I often get questions like, well, what do I do after metformin? Or what do I do if I can't get this done or this covered or something? And I always tell people it depends. It really depends. And people never like that answer because I think people feel like that's a cop out, but that's the best that I can give you because our care should be individualized for each patient. Everybody has different things and layers to their life, which affects their care, whether it be their insurance coverage, whether it be, other comorbidities, whether it be that their preferences. Here it says that our care should consider, I'm trying to find the individual's preferences, their prognosis, their comorbidities, and that they're informed about the financial considerations. Those alone, which there are other layers there, but that alone will really drive what care you're going to do. You know what I'm saying? And so I find that a lot of people, I don't know if people are not comfortable with individualizing care. It is a muscle that you do have to grow, but they really emphasize this through all the standards pretty much. So that's that on that. Let's see here. Let's see. Something that I wanted to bring up here. We get into, let's see. I'm looking here. Okay, something that I really like, and I thought it was, this is the geek in me, but I thought this was like beautifully written. I like how they put it. It was saying clinical practice recommendations, whether based on evidence or expert opinions, are intended to guide an overall approach to care. The science and art of healthcare come together when the clinician makes treatment decisions for a patient who may not meet the eligibility criteria used in the studies on which guidelines are based. Recognizing that one size does not fit all, the standards presented here provide guidance for when and how to adapt recommendations for an individual. And so I love that because I love this idea of the art and the science of it. And I feel like many people can practice more on the science side, but not on the art side. I think people are very, and I used to be like this too, especially when I was learning diabetes and getting more comfortable with managing the different care and maintenance and stuff like that. I just really just did everything by the book. Everything is like, okay, what does the algorithm say? But what I found was sometimes it is not a one size fits, most of the time it's not a one size fits all. And so you have to use your clinical judgment. Your clinical judgment comes from it's just a muscle that you have to build. And I find that there are a lot of people who don't have that muscle, but you do need to develop it, and you can do it. It takes time, but you need to develop it. So that's why you can see a lot of different normals. You can see a lot of different abnormals, and they're all different variations. And so I really love that. Let's see, going next to the care delivery systems. So I wrote here, people with diabetes meet individual cardiometabolic targets, but not so much all as a collective. So it includes here that like we get into this and it's talking about how like people were meeting, like if you have diabetes, they were saying individuals with diabetes, maybe there were so many of them that would maybe meet the target of blood pressure. So many would meet the target of cholesterol management. But overall, it was not like people were not meeting the targets across the board. So it talks about that and how there's much work to do. It also talks about the cost of diabetes, which is astounding. And basically, it refers back to 2017. So there's probably still data that's going to be coming out that's going to be reported on. But it says that in 2017, 327 billion was the cost. And this included direct costs, which were 237 billion. And then the indirect costs was one of the indirect costs was 90 billion in reduced productivity. And so there is actually a website that is through the CDC that gives us basically like our diabetes report card. And it tells us like how many people are affected. It's very robust, and I can link it in the description box, but it's very robust. But what happens is that a lot of people don't realize that the cost of diabetes is not just the direct costs, like someone going into the hospital and, people paying for medications. There's a lot of indirect costs. There's a lot of time away from work. There's a lot of decreased productivity. There's a lot of absenteeism from work. We talked about that. I just said that. And then also something called presenteeism, which is you're at work, but you're not fully working at your full capacity for one reason or another. Maybe someone has a hypoglycemic episode and has to step away and, go to the bathroom. Different things like that. Like the person's present at work, but they're not fully present. And so this is not just a problem just for the clinician. It's not just a problem just for the patient, but it's also an issue. It's literally a population health issue, because this includes our employers, this includes the payers. So this is an issue that we all need to be on deck, on all hands on deck for with this. So next thing, they talk about the chronic care model, which is, and I'll define this for you. So there's 6 core elements here. It's delivery system design. So moving more so from reactive to proactive. So that means prevention. Okay. That's early screening and detection. That's using risk factors to help guide us there. And then self-management support. I've spoken a lot about self-management because we know that when people are very well versed in what their condition is and they play an active role, we get better outcomes. Decision support, basing care on evidence-based and effective care guidelines, things like this, right? Then clinical information systems, using registries that can provide patient-specific and population-based support to the care team. And then the fifth one is community resources and policies, identifying and developing resources to support healthy lifestyles. And then lastly, health systems, which is to create a quality-oriented culture. And so this is what they're saying, that the chronic care model, there's six core things, and that like the effectiveness of it, and they give us like a 5-year study where that by doing this, when we adopt this model, we have increased health outcomes, lower the cost, not and for the individual. And so it actually gives like in this study, this 5-year effectiveness study for the chronic care model, it actually resulted in healthcare savings of $7,294 per individual over the course of this study. Now, in this study, there were 53,436 people in this study. So each person had reduced cost about 7,200. So when I did the math with that, that comes out to 389 million 762,184. So around about $390 million is the savings for just this one study. And this was just 53,000 people, And so anywho, it's basically telling us that this model, when we adopt it, we're going to save money for the individual, which also saves money for the system. And so thought that was very interesting. Goes into talking about the next thing is we talk about efforts to increase quality in the diabetes care, which I think we all can agree that we could stand to do that. And then there's also something, the pluralistic needs of people with diabetes need a diverse team. And I wrote here, what would that look like? You know what I'm saying? That's not, they didn't say this, but as I'm reading, I'm thinking to myself, okay, so it's saying that the pluralistic, I can't speak, needs of people with diabetes need a diverse team with complementary expertise. And then I just wrote in parentheses, well, what would that look like? Well, for one, that looks like us not working in silos. And I find a lot of times, especially being that I don't serve as a PCP in my current role anymore, I am more of a consultant, more of like an adjunct, and have been for some years now. I find that a lot of people try to do everything in-house, but they can't. You can't. And it's like I see so many people who have never been to a dietitian. I've seen people who don't go to the foot doctor. People don't go to the dentist. I understand that some of this is expensive. Some people's coverage doesn't cover all of this, but like, you can't do this all by yourself. And so it's calling for us to realize that with all the different needs that a patient may have and will have, you have to bring in a care team. They have to have a team, and that their expertise needs to be complementary. So we do need to work collaboratively. I really like that statement. And so let's see here. Okay. What else do I have? We talk about telehealth. They define this, and I saw somewhere some article where maybe AANP had announced this, but they've extended. So when we went into COVID, because we couldn't be around each other, telehealth, the restrictions were lessened, and any and everybody could do telehealth. Payers were paying for it because that was all we had. Well, we're still in COVID, but now that we're not in the height of it, it allowed that extension has been made. I want to say to 2024, I might have read, but it's been extended a little bit more, or maybe it's 2026. I can't remember. But basically, it's basically saying that, like, because at one point in time, telehealth was really only covered for those who were working in mental health, in areas that were rural and people didn't have access to stuff. But then, of course, when COVID happened, like we all could do it, and there really were no, restrictions because that's all we had. But now they've extended that, and they do define telehealth, what it is. So the definition of telemedicine is the use of medical information exchanged from one site to another via electronic communication to improve patients' clinical health status. And this includes the synchronous, asynchronous, and remote patient monitoring. So asynchronous was like if someone, you don't have to both be at the encounter. Synchronous is that we're here together. I'm on a call, video call chat with you, and we're going back and forth. We're here together, we're synced together. But asynchronous is if there are some apps where like someone can fill out a questionnaire and you get a message and you can look at it at a later time. We don't have to be there together doing it together. And then of course, patient remote monitoring, the remote patient monitoring, you'll see this a lot with CGMs, even with insulin pumps and stuff, you're not with the patient, but you can get the patient's numbers. You can look it up. They're connected to your system. And so all of that is under there. And it says telehealth should be used complementary to in-person visits to optimize glycemic management in people with unmanaged diabetes. And I thought that was really interesting because I do find that I have seen, which I don't, it made me think of people who have like companies where they're doing everything online and virtually. And what this is saying is that it should be complementary. Like it really should be complementary. Like you shouldn't do everything virtual. And I get it. And I think that telehealth is still a new place for us all. And so I'm really interested to see what the coming years would look like, because I really do believe that we're going to get to a place where everything's probably going to be done virtually. I see it going that way. I think how we utilize our tech, we will be able to do that. But I can see that the industry is not, there's, and I get it. Like there are things that you are limited when you're doing things like virtually. But there's a lot that we could do more virtually. Like you can't do a foot exam, you can't get blood pressure and stuff like that. But I'm interested to see what's to come, outside of this. I'm interested to see how healthcare is going to look 5 years from now. Okay. I'll just leave it there. Okay. Let's see here. One thing they do say is that telehealth resources can also have a role in addressing the social determinants of health in young people with diabetes. I was a little interested, like why just young adults with diabetes? Why not everybody? I can see it being beneficial for everyone when it comes to SDOH, but maybe I was reading too fast and I was like, why just young adults? You know what I'm saying? No, this is what I was thinking. Let's see. We talked about that. And so then we get into behaviors and well-being, and we do talk a little bit more about social determinants of health. I think that's, maybe I didn't. Yeah, let's go ahead to the next one. So the next section is tailoring treatment for social context. So really assessing your SDOH, and they kind of spell it out here. Assessing for food insecurity, house insecurity, financial barriers, things like that. And then also provide patients with additional self-management support from lay health coaches, navigators, community health workers when available. Then the third point in the next section is consider the involvement of community health workers to support the management of diabetes and cardiovascular risk factors, especially in underserved communities and healthcare systems. So they do define what SDOH is. I've done a lot of videos on that as well, because that's a big thing, for me. And it's defined as the economic, environmental, political, and social conditions in which people live and are responsible for a major part of our of health inequality worldwide. And let me read the statement that they say here, the next statement. The ADA recognizes the association between social and environmental factors in the prevention and treatment of diabetes and has issued a call for research that seeks to understand better how these social determinants influence behaviors and how the relationships between these variables might be modified for the prevention of management of diabetes. So basically, we know that SDOH is something that we cannot overlook. Okay. A good definition that I found, it's the non-medical factors that affects people's care. It's where they work, it's where they grow, it's where they live, they do life. So this is where they're at the majority of the time when they're not with us. Okay. We only get a snapshot, but they're calling for more research of how this affects people. And I'm interested to see where this is going as well. And something that I have said this before, and then with my consulting business, with my diaspora approach, this is one of the things that I talk about, and I feel like we need a more routine, we need a tool. Everybody should have a screening tool when it comes to SDOH. Otherwise, it's not properly caught. And it says here, SDOH are not consistently recognized and often go undiscussed in the clinical encounter. And I know that to be a fact. There are a lot of things that I pick up, especially being that I am not the PCP. And because I do a routine screening of SDOH, I am asking about stuff. A lot of times people are not even being asked. And this is the first time somebody's even asked them. And so it always blows my mind, but I find that a lot of times people don't have a tool. Just like we have the mini cock, we have the PHQ-9. You also should have a screening tool for SDOH. And with with the diaspora approach, I actually give people resources to how you can have a routine, formalized screening tool. Something that's simple, but something just like I said, just like how we do the PHQ-9, just like how we do the mini cog, we should be doing the same type of screening for SDOH. Okay. So talk about that. Let's see what else we got here. We're almost done, guys. Let's see. They do define, and just on that note, let me go back just quickly. It says, in addition, brief validated screening tools for some SDOH exist and could facilitate discussion around factors that can significantly impact treatment during the clinical encounter. So they talk about this. There are screening tools that are out there, and we should have that a part of our encounter. They define food insecurity, which is the unreliable availability of nutritious food and the inability to consistently obtain food without resorting to socially unacceptable practices. And so that's a big one. One of the things that I think a lot of people don't understand too with food insecurity, it's also food deserts. I have been to places where there's no grocery store for miles. And when you're thinking about somebody who is elderly, someone who probably doesn't drive a lot, a 15-minute drive could be the world of difference for someone. Like for me, 15 minutes to go hop down somewhere, to go to a place that has good nutritious food, go to a Trader Joe's or a Sprouts or a Whole Foods. But you're dealing with people that may have fixed income, people who have limited vision, maybe people who live in areas that are very high traffic and they don't feel comfortable driving. What about those people? And so that is where I have seen in my practice what could be an issue. It's not always so much, and I'm not saying that this doesn't exist. I'm just saying in my own personal practice where I have seen where food insecurity, it's like they said, the unable to obtain nutritious food, because also keep in mind food deserts. And so that was that. Let me see if there's anything else. It does talk about, which I love this because I love this pointing out, because I don't think people really know how food insecurity will really affect a patient. And I always go back to, let's talk about a food desert, right? So there's one neighborhood that I have frequented when I have done visits and seen patients in the community. And in this area, there was a solution that eventually came, but in this area, there are no Walmarts, no Kroger's, there's no grocery stores. And so, but what normally is there are corner stores. But think about what's in corner stores. You're not going to have fresh produce, fresh cuts of meat. You're not going to have stuff like that. You're going to have a lot of packaged food. And so what they point out here is the effect of this being hypoglycemia, and it's swinging to hyperglycemia. So hypoglycemia, if a person doesn't have enough food and they're dosing themselves insulin, you got a high risk for hypoglycemia. But something else to consider is the hyperglycemia, because people will pay for what they can afford. That's why fast food, packaged food is so affordable, but good food, real good nutritious food is more expensive. Well, if people have to make a decision, what do you think they're going to make? They're going to make the decision to go get the burger, or to get some noodles at the corner store, some ramen noodles, which is so high in sodium, and all the other stuff that has all these fillers in it that really will cause their blood sugars to go very high. But if we're not talking about this with our patients and we're not screening for this, how would you know? And then what happens, what I see happen a lot, is people end up pegging these people as non-compliant or non-adherent, but meanwhile, they've been eating what they can afford. You see how we have to not be in this role of being judgmental and ask more questions and listen. You know what I'm saying? You can find out a lot from people, right? And we do need to know how to help our people and help our patients through issues like this. Okay, so that was something to talk about migrant and seasonal agricultural workers. I have not had a lot of experience with migrant and agricultural workers, because I've typically not worked. I've worked more urban than rural, but they point out you can only imagine they have to go where the work is, right? So you got people who are like, they may be here for 6 weeks, but then they may go to another state, a neighboring state, for another 6 weeks. So the difficulty and the complexity with taking care of this population, because they're just not, they could be here today and gone tomorrow because they're going where the work is, right? And so realizing that some of them may not have, the means to store insulin. Follow-up is going to be challenging, and they give guidance here too. So it says here, migration, which may occur as frequently as every few weeks for farm workers, disrupts care. It does. And in addition, cultural and, I'm not going to read that part. But so anyways, that was that. And then let me see, I'm trying to make sure I don't miss anything with my notes. And then they talk about health literacy and numeracy, and they define that as the degree to which individuals have the capacity. Health literacy is defined as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate decisions. And then they also, I want to say, health numeracy requires primary numeric skills, applied health numeracy, and interpretive health numeracy as well. Something that I often like to point out here with this is this. We can have a idea in our head what someone who does not have health literacy and numeracy looks like. And you can miss a lot of opportunities. Now, health literacy and numeracy is not someone being illiterate. And I think sometimes we can have that in our mind. People can be very learned people, but don't understand the terms that we say to them. And so education, communication, educating to the person's level, always asking questions again, making sure, do you understand what I'm saying? Can you tell me what I just told you back? Because I have seen people who have multiple degrees. I've taken care of people who have multiple degrees, very successful people, and yet They have very low health literacy and numeracy. Especially when you're thinking about the numeracy, you need to think about, are people able to do basic calculations? Do they know do they understand the numbers that they see when they're doing checking their blood sugars and things like that? What does that mean? What should they do? You know what I'm saying? Like, you got to make sure that they know that. And so they talk about that as well. I think that's important. And then lastly, community health workers. And so the American Public Health Association defines that as the frontline public health worker who is a trusted member and or has an unusually close understanding of the community served. And then it says the scope of the community health worker in areas such as outreach and communication, advocacy, social support, basic health education, referrals to community clinics, has successfully provided social and primary preventative services to underserved populations in rural and hard to reach communities. So good healthcare, community health workers. If you are a clinic in a particular community that maybe outsiders are not, I can think of a few different types of community, different cultural groups. This is where a community health worker would really help. They're a non-medical position, but they're in the community. They are part of the community. And so they can act as a bridge. Something else that I also like to point out to people too, don't steer away from hiring healthcare professionals that are a part of the community. I mean, really honestly, you know what I'm saying? Like, I've said this before. I remember, I don't know if I was on Indeed or something like that, and I literally saw a posting that said, looking for a Mandarin Chinese speaking nurse practitioner, would prefer you be in Chinese yourself. Like that, basically. I mean, of course, it did say it exactly like that, but that's what it was. And it made me stop. And I got to thinking to myself, I was like, I mean, that makes sense. Because when I think of different cultural groups where it's like, it's very insulated, there's not a lot of people in the community that are not a part of the community. And so we go and we plop our clinics there. And, you wonder why people don't seem to trust you. They don't seem to come into your office and they don't come back. Well, you're looked at as an outsider, and that's okay. It doesn't mean that you're not a good person, but it just is what it is. And so I do think this is where community health workers would do great work for you and be your bridge. But also, I would like to say this too. Don't just rely on the community health workers. Like, you yourself need to be in the community. And I see too many people that want to stay within their four walls of their community, their clinic. And yet you got to be in the community. Okay. If you want people to know, trust you, you need to be out there in those streets. I'm just going to tell you that right now. And it's not a hard ask. It's not a heavy lift. You know what I'm saying? Just get out there. And I think, we got to be creative with how we do that. And also hire people from the community. I've said this before, and I had somebody to write. I could tell that I offended people. But my thing is, a hit dog will holler. If you know this ain't you, then it shouldn't offend you. But I do believe that, I see this a lot with people hire community health workers. And I'm not saying that you shouldn't, but you also need to hire people like your nurse practitioners, your doctors, your nursing assistants, your MAs. You need to be hiring people that are a part of that community. So for instance, I had made the comment about if you heavily see African Americans or black community, or you heavily see a Hispanic, you doing Hispanic community, or Chinese, Korean, or what have you, LGBTQ, I plus, wanted to make sure I got that all in. It would not hurt to hire people that are from the community. If you're in a black community, there should be some black providers in there. If there is a community, a Korean community, you should have people in there that are Korean. because not only are they going to be able to relate to the people, but they're also going to be able to educate the patients on a level that you may not be able to, and also be able to teach others in the clinic about that. And I'm not saying that only Black people should take care of Black people, and only white people should take care of white people, and only Hispanic people should take care, and so on and so on and so on. No, I'm not saying that. What I'm saying is representation matters. And if you find yourself not getting the outcomes that you want, like I'm doing all this work and I really care about my patients, but yet they don't ever come back, or they don't seem to trust me. It seems like, you feel like you may want to think about that. And so I hope this don't offend other people. I don't care. Really, I don't really care, because the one person, she was like, I'm the only person at my clinic. And ma'am, I'm not talking about you then. Like, if you know you're doing the best you can and you can't hire, because I know that everybody's not in a position to hire that. You know what I'm saying? But if you do have the opportunity and you are looking at candidates, you do want to think, and that's just common sense, y'all. Like, come on, like let's not argue over common sense. Like, again, don't get offended off of stuff that we can all agree to, whatever. So anyways, y'all, that's all I got on that one. These probably will be a little longer than my lunch and learns, only because I'm having to go through, and this was a rather short one. So some of these rest ones, I'm gonna try to get through them a little quicker. But I hope you guys like this. I'm going to link the first section in the description box. And yeah, so thank y'all for sitting here with me. I'll catch y'all tomorrow for standard 2. Bye.